RCS. So thank you very much for that. So we are just starting our next session, which is more focused on obs and gynae and anesthetics. So we've got in our panel Dr. Soha Sobi, who is an obs and gynae registrar and an academic clinical lecturer at Queen Mary, University of London. And then we've got Dr. John Dalton, who is an ST6 in ONG at the Mid-Yorks NHS Trust, and Dr. Rima Patel, who is a CG2 anesthetics in East Midlands School of Anesthesia.
And I'm really pleased to introduce to talk about mHealth, Dr. Sorry, Dr. Shobhi Nagraj, because I love hearing her talk. She's got an amazing career path, so I'm not going to tell you about her career path. I'm going to get her tell you. So thank you very much. Thank you.
Thank you very much, Sarah. And thank you so much for inviting me to speak here today. So as Sarah mentioned, my name's Shobhi. I'm actually currently based at the George Institute for Global Health and the Nuffield Department of Women's and Reproductive Health at the University of Oxford. And I'm doing a PhD at the moment. So I wanted to start by sort of telling you a little bit about my journey and who am I and why am I talking about technology. And if you're anything like I was when I graduated from medical school, I thought that you qualified as a doctor and then there was this very straight career path to becoming a consultant or to becoming a GP. And my path was actually very different. It was more like this. So I actually started off, like many of you, as a trainee as a surgeon. I had my number is in paediatric surgery, and I was completely immersed in the NHS and hospital life. And I think I reached a certain age where I thought maybe it was an existential crisis, but I kind of thought I want to do something different and I want to get more involved in global health and travel more overseas. So I took a couple of months out and I went to live and work in Malawi in paediatric surgery. But at the time, it actually exposed me a lot to health systems and public health. And I could see how if you really wanted to make a difference in certain low resource settings, you really needed a background in that. So I actually came back to the UK and retrained as an academic clinical fellow in general practice. And I did health services research looking at really big data sets. And after I finished my training, I returned to rural India to work and live for a year. And that really kind of exposed me to some of the complexities of living in rural areas. And I came back to the UK and I immersed myself in medical education. And it was during this time that I started to get involved in technology quite by accident. So somebody had asked earlier, how do you engage with tech people and biomedical engineers? And actually, I think the best way to do that is through things like hackathons. So I'm really glad that we're having that this afternoon as well. But just out of chance, I happened to be working in a city that became a city of sanctuary for refugees, and I got involved in migrant health. And through that, I was invited to help design an app for migrants entering the NHS. And it's the first time I'd worked with coders and developers and IT professionals, and I had an absolutely brilliant time and just had so much fun. And I started to think, why can't we do this kind of thing in hard-to-reach areas? Because these are people who had very minimal health literacy and didn't know the health system, but somehow technology had bridged all of those gaps. And around the same time, a friend of mine sent me a BBC documentary about a technology called Smart Health, which had been developed by the George Institute for Global Health. And I thought, sorry, I've got a cough. And I thought that this might be really applicable to maternal child health. So I emailed the director of the George Institute for Global Health, and that's how I came to be doing my PhD in Oxford now. So I'm working with their team in technology around that. So that's my path to maternal child health and technology. So what really excites me about technology in medicine is really just how cool some of the innovations are. So we've heard a lot about this today. But I don't know if you know, but there are now things like smart bandages. So there are electronic devices that you can put on the skin that detect micro changes in vasculature and pH, and they can detect wound infections much earlier than we can clinically and release antibiotics into the wound. So these are the types of technologies that are now available. Also augmented reality, so actually in your own environment, but projecting another reality onto that. So Microsoft have developed a HoloLens. It's like a sunglasses device, which is now FDA approved for surgery in the United States. Virtual realities, which I think we've heard a little bit about, which I'm involved in another project in Kenya, which is led by a team in Oxford. And then coming to phones and wearable devices, which I think are really going to change the landscape of healthcare. So Apple have now decided that health is their new area that they're going to invest in. And actually this is going to change the way that we work as doctors as well, because those doctor-patient relationships are going to be much less hierarchical, and patients are going to come in actually knowing what their diagnosis is, which is quite complex for the future. Out of all of these, however, in the kind of places that I work, I actually think mobile technology is the most important. And we've seen a lot of maps of the world today about safe surgery and which countries are affected by this. And also, if we look at maternal mortality, the map looks very similar. Sub-Saharan Africa and India have the highest rates of maternal mortality. But I'm going to kind of flip that on its head a little bit and show you a different map. So this is a map of the global reach of Pokemon Go. Okay. So for those who don't know, does everyone know what Pokemon Go is at all? No, well, some of you do. So Pokemon Go is a free downloadable smartphone app, a game. It's a game, and it uses augmented reality technology, and it can be used anywhere in the world, and it projects these Pokemon or pocket monsters onto your world, and you catch them. And up to date, since it was released in 2016, it's actually, if you look at the global south, almost 500 million people have used and downloaded and are still actively using the Pokemon Go app. So I think sometimes in medicine we become really siloed into our own ways of thinking, and we actually need to start thinking about how other people are reaching people in hard to reach areas and actually the health effects of those. So Pokemon Go, you have to go out into the community. So I identify as a millennial, so nothing against millennials, but it got people out of their houses, engaging with other people, and also having lots of fun in the process. So I kind of devised this table for Pokemon Go, and I think it possibly had more of a health education effect on physical activity than any other intervention, because it got almost 500 million people outside moving. It encouraged critical thinking and friendships and interaction. It started to think about global partnerships and learning about each other's contexts. And arguably, these are things that we really want to do as medics and surgeons. And it's had over 1 billion downloads to date. It has a global reach. And it's free, but through the in-app purchases, it's generated over $3 billion of revenue. And while we're not really taught to think on financial terms as medics a lot of the time, you just think what money like that could do if it was invested in surgery. Slightly negative effects of this are that it uses your GPS location, so it is amenable to stalkers, which unfortunately is a side effect of this. And with any technology, and as we'll see, I think when you start talking about this in the hackathon, is the data is really important. Data is now the most precious commodity in the world, and actually how we use that data is something that's quite important, how we store that data. And Pokemon Go actually did lead to an increase in car accidents because people were quite distracted. So in the first week of download, apparently there were attributable car accidents due to that. So what can we learn from the gaming industry? Well, I think these are some principles which I think will be really helpful when you're doing your hackathon as well, is that really, games are simple and they're fun. They transcend boundaries. the Pokemon game in particular engaged the community, and it actually physically engaged the person within their local environment, and it promoted this kind of interaction between the game, the technology, themselves and their environments, which is something really clever. So when we're introducing technology into health system, to start thinking about how we integrate it into the lives of the people who are using it, rather than just an add-on. The other thing about Pokemon is that it actually considered all types of users. It transcended language boundaries, cultural boundaries. It did have some problems in terms of internet connectivity, which are kind of becoming much more widespread now in terms of mobile coverage. And it didn't address some marginalised groups, which is something that we do need to think about in healthcare. So how is this all relevant to the work we do in maternal health? Well, I work in rural India, and this is one of the places that I work. It's in a northern state called Haryana, and Haryana is famous for a couple of things. It's one of those states that's actually has the highest rates of gender inequity in India. And actually, a few years ago, they had to import brides because there just weren't enough women for the men to marry. And the reason for that is that historically, they were practicing female infanticide a lot in these states. Now it's illegal, so sex selection, abortion can't happen, but it had been happening. So there's some cultural issues around that when you're working with women, particularly when you're looking at interventions at the home, where you have to engage the men of the household as well as the mother-in-laws as well. And the other thing about the area I work in is that there's lots of brick factories. So the women that live and work at these brick factories, they earn about 30p a day, and they have a daily wage. So if they don't go to work, they don't earn any money. So you can imagine trying to engage those women, who are mainly migrant women from other poorer states in India, and they have tents pitched up outside the factories or in nearby villages, so they don't actually have any fixed abode. So trying to engage them in a health system and encourage them for safe delivery of their babies in a hospital is really hard, because they won't leave work for even a day, even if they're close to death. So these are some of the things that we need to think about when we're introducing technology into a health system. The lovely bridge to these women and the communities. In India, we have women from each of the villages who are called ashas. And asha means hope in Hindi. And actually, they are the hope for many of these women. And they are community health workers who are from the communities that they live in. They look after the healthcare of their communities, particularly around maternal child health. And so I've been working with the ashas to engage them with mobile health technologies, because they have a secondary school education and they're able to actually then manage some high-risk cases in the community and know when to refer on to primary care. So the things that I've kind of learned from this work, and I know time's a little bit short, so I'm just going to run through this, is that a health system is a really complex and dynamic system. So whenever we introduce technology into a health system, we're actually introducing a complex intervention, and we need to think about technology more as a complex intervention. So there are frameworks and strategies and theories that may improve our chances of it succeeding to scale and to be sustainable. So I use a particular framework called the MRC framework for complex interventions, and this is actually going to be updated later this year. But it takes you through what you might think about as you're developing and testing out an intervention. And it's really about getting all the context right, getting the evidence, and then actually looking at modelling what the processes and outcomes will be, and then testing that out in terms of pilot testing, evaluating it, and then implementing it. And for that to happen, something that we need to start thinking about is health systems thinking. So thinking about what's going on in the health system, what's the context. The government changes every 3 to 5 years, depending on which country that you're working in. How is that going to impact on your technology? Are there new guidelines and targets that you need to meet in order to meet those government guidelines and targets? And then think about the users. Are they confident in using technology? Do they have the knowledge to be able to use it? And we want to avoid them duplicating their work. So how do we address that? And then if we're aiming our intervention at the public, then again, what do they actually need? And is it going to be simple and fun for them to use? And does it fit in with their existing cultural practices? So there's a few steps that I had about ensuring sustainability and scalability. And I think the lady from the WHO mentioned it before, but human-centered design is an approach that we can learn from the technology industry, which really brings empathy and context into what we do. And it looks to the people for inspiration, and then you brainstorm together and then you implement things, and then you do it in rapid cycles. It's something called agile methodology. So you do iterative cycles of development, keep coming out with new things, which is a new methodology that we can actually learn from. Use participatory methods, so involve local women's groups, and that's actually improved the uptake of these interventions in their communities. Engage government and stakeholders early, and think about cost effectiveness and evaluation. And most importantly, as one of our speakers mentioned before, publish, because you can help other people through publishing. So just very quickly to show you what a human-centered design approach looks like, so hopefully you can use this afternoon, is that you go into the shoes of the people that you're trying to help, and you follow them through their daily lives, gain that insight into what is important to them, and then you ask really empowering questions like, how might we do this? If you had all the money in the world, what would be the best thing that you could do? And then brainstorm, ideate, create a prototype, and then test it out, and then keep doing this again and again. And that goes on forever. So Google still, although the search engine looks exactly the same as it did 20 years ago, it's actually a new search engine every day, but we don't notice those changes. So very quickly, just to finish off, the challenges of evaluating technological interventions are that because they're complex interventions, those kind of study designs that we use in medicine, like randomized controlled trials, might not show an effect because the complexity of the things involved. So sometimes we can think creatively about how we evaluate things as we go along, something called process evaluation, and then also think about assessing impact in a creative way, such as economic and social impact as well. So in conclusion, for this afternoon, I think choose an area of need. Who's the intervention aimed at? The macro, meso, or the micro level in the health system. Use human-centered design approaches, decide on what outcomes you want to measure, and the evaluation and study design, and addressing sustainability and scalability. And I'd just like to end with a quote from, this is the founder of the Taj groups of hotels in the city I was born in, which is Mumbai. And he said, in a free enterprise, the community is not just another stakeholder in business, but is in fact the very purpose of its existence. And I think that's really important, that we put the community at the heart of anything that we do in terms of technology development. Thank you.
Thanks very much, Obi. So we're just going to take some questions for 5 minutes whilst we get our colleagues from Rwanda on.
Do we have any questions in the House? Thank you very much.
Thanks very much for your talk. It was great to hear you talking about complex systems and how it's difficult to analyse and prove an effect of what you're doing. I just wondered how you'd found sort of justifying your work when using sort of process evaluations, and how it is with funders and things like that.
Sure. So I'm actually funded through the Medical Research Council, and more they're looking at process outcomes as part of randomised control trials and any other trial design as well. So actually it's a field that's really developing, and I think it is because of the reason that we sometimes are measuring the wrong things. So we're just going for those hard endpoints like maternal mortality or surgical outcomes, but actually the experience throughout the feasibility, acceptability, the small changes that occur in the microenvironment are just as important as well. So I've actually found it that funders want you to do process evaluation and to include that in your study design.
Are there any other questions? Oh, yes, at the back.
Thank you, that was really interesting. Could you tell us a little bit more about specific examples of projects that you're using mobile technologies with these women in India, please?
Yeah, sure. So I'm involved in two projects. One is related to my PhD project, which involves smartphone technology in terms of tablets to provide clinical decision support to community health workers in rural India, and that's around high-risk pregnancies. I also work with another group which uses smartphone games to train health workers around neonatal resuscitation and virtual reality to do the same in Kenya. And those are two sort of projects that I'm happy to talk personally to other people about if they're interested.
Okay, we've got a question from Rwanda now, if you can hear us in Rwanda. Joseph, can you hear us over there? Can anybody hear our Rwandan colleagues at the top? Clever. Okay. Let's just see if we can get hold of...
Joseph, can you hear us?
While we're waiting to solve that technical hitch, any more questions from the floor here? Oh, yes, we've got a question on the right. Here, please. Thank you very much.
Hello. Having just graduated from medical school and entering this world of global surgery, I feel like my research teaching is incredibly outdated. There are so many things that we're exploring in terms of study design, like you said, sort of outcome measurement, that I'm just not familiar with at all. And it's actually a really big obstacle sort of preventing me from engaging with academic discussions around global surgery. I don't know how many other newly qualified medics or medical students feel the same way. I wondered if you had, should we be trying to change medical school teaching, or is there any way to get people engaged and make these sort of research methodologies more accessible?
Sure, I think that's a great question. So I think it's come up quite a lot earlier today as well, which is how do we actually get this into the academic world and published and out there? The answer is, because it's relatively new, the methodologies are being developed. There's a new field which I work in now called implementation science, which I think is completely amenable for global surgery. It seems to fit because it's really practical, and it's looking at those practical considerations of how you get evidence-based interventions actually working on the ground. So we know that 90% of interventions that are developed don't actually have any real-world benefits, because somewhere along that chain of getting to the people, something's not working. So I studied that, and it's called implementation science. There is a UK implementation society based at King's College London. It's a field that we're developing now in Oxford as well. And it's something that there's a journal of implementation science, and it marries now with the new MRC framework for complex interventions, which is coming out later this year, which is looking at complexity theory and health systems research as well. So when I think about my career path and the wiggly route, I didn't know how it all made sense until afterwards, but now I can see how my health services research background is actually very applicable to global surgery. So the answer is that these study designs are out there. They're relatively new. There are a small global community that work on them, and also now in terms of drug-related research as well, adaptive trial design, or this iterative approach to trial design, is becoming apparent, although it's hard to convince funders to fund you for that, because the statistical methods are quite complex to keep looking at iterative cycles.
Thank you very much. Can we just go back to Rwanda now? Can you hear us?
Yes, we have two questions. Let Magnifique start.
Fantastic.
Thank you so much for the presentation. My question is about the scalability. Most of the innovations that come around, you find out that you've done a great job, you've got great findings, but when you want to scale up, the politician or whoever that needs to actually take it up to be, to roll it up, they're hesitant to actually put it into action. So I'd like to ask, what would you advise in this? Is there anything that you can actually give us a tip on how we can actually go? Because there's something that we've been doing here, but when you try to convince people to scale it up and roll it up to other people, it's always a big issue. So I wanted to hear your point on that. Thank you.
Thank you. Fantastic question. So really important. And again, this is where implementation science becomes a really important skill and methodology to use. But number one, it would be to engage those government stakeholders right from the outset in what you're doing. Involve them in meetings, go and meet them. I've spent hours outside politicians' doors, sometimes you feel like you could be doing other things. But make sure that you have those conversations early and every step of the process to involve them. Once they feel an ownership over it and they feel that they've contributed to it, they're much more likely to adopt it. And also they can provide really valuable inputs in terms of what's needed from a policy perspective as well. So policy often talks in a different language to medical research. So I think having advocacy and this sort of a policy type approach to your research is really important. So that's combining quantitative data together with some qualitative work as well and presenting that to them. So that's what I found useful. I hope that helps a little bit.
Thank you very much. Now, we're better to try and keep to time. It's with great pleasure that I introduce Mr. Tim Beacon as our next speaker. He's the CEO of Medical Aid International, which works to improve healthcare across the world through supplying medical equipment, accessories, training and biomedical support that it is context appropriate, fit for purpose and tailored to the individual project. He's an ODP by training and we'll talk about biomedical engineering concepts in LMICS, focused on both practical and training needs and how he solved these problems and which is what gave rise to MedAid International. And I've known Tim for many years now, and I must say that he's a real can-do man. I don't know how he achieves so much, but if you've got anything that you need doing, have a word with Tim after he's given his talk, obviously, and he'll be able to get it done, I've no doubt. Thanks, Tim.
Thanks, John. It's a real pleasure to be here. What a great conference and fantastically organised. It's just a real privilege and a real blessing to be here. So thanks for listening to me, and I hope we have a really good time. It's been so interesting to hear everyone else's words of wisdom. So yeah, my name is Tim Beacon. I'm the CEO and founder of Medical Aid International. We're a social enterprise. What that means in English is no one gives us any money to live. We have to earn it. So when we do our projects, we have to charge for it. But we also, through our business model of reinvesting our profits, but also negotiating on our clients' behalf, we save people an awful lot of money, hundreds of thousands on occasions, in the projects we do. Anyway, so that's kind of who we are and what we do. So, what do we do? Well, we specialise in providing the right equipment to the right people at the right time in low to middle income countries. And we provide a whole sort of holistic support structure in that process. We do all the logistics, we can install, we do training, including biomedical engineering, and we do the aftercare as well. And the nature of our work is that we're in country a lot, so the great thing about that is if we're doing one project for one organisation, we can go and look in at all our other projects at the same time to check that everything is going all right. And so that's a project we did in Madagascar for Mercy Ships, part of their capacity building programme. When I first went in there on a recce visit, it was like, this is kind of one of the worst I've seen. But by the time we'd finished working in partnership with Mercy Ships, this is what it looked like, which is a lot better, basically. And all of that equipment, and I could talk for an hour on that slide, to be honest, is designed for the environment in which it's in. Self-contained anaesthetic machine, manual operating table, LED lights with a battery backup and so on. And we did in that hospital ICU, we did the maternity fistula unit, and we've got a container ready to go out for the maternity unit funded by the UNFPA and Mercy Ships. So that, and we also trained the biomeds on the ground. Now, biomedical engineering, because with this talk, what I'm going to do is I'm going to talk about biomedical engineering, but it's equipment supply, practice, biomedical engineering, they all combine, they're all interweaved. And so we run City and Guilds approved biomedical engineering courses. It's been a fantastic blessing to do that. We had a hospital in Haiti that we did a 2-week intensive course, practical, down-to-earth stuff, supplying them equipment, test equipment and tooling at the same time. And the British CEO said to me afterwards, we repaired 80% of the unworking hospital equipment, because so often, in terms of broken equipment, the solutions are actually quite easy. We'll come on to that later on. So who am I? Very briefly, in no particular order, I worked for about 13 years in the orthopaedic industry in trauma, mainly. So I did a lot of Ilazarov work, which was great when I supported Leeds Uni on their fantastic orthopaedic research project that they're doing in Sierra Leone. It also helped me to really understand industry, which is something I spoke about briefly in the Q&A earlier. It's really important that everyone is involved in this approach to helping these people less fortunate on ourselves, and that industry has a massive role to play in that, and understanding how they work, the fact that they can have ex-demonstration products, the last year's model and so on, all equipment that we can potentially use in the environments in which we work. I trained as an ODP. Now, I know I don't look old enough. Trained as an ODP in the mid to late 80s. So that was when pulse oximetry came in whilst I was doing that. Capnography came in at the end. So we were very good at feeling pulses, basically. We didn't have laryngeal masks, so it was very good training, basically, for what I do now. For about 20 years, I ran an adventure training business, running team building and leadership courses, mainly for medical staff and largely for orthopaedic staff. I worked with as a civilian. I've never been in the military. 5 years I was teaching the British Special Forces on their medical course, so I was privileged to do that, and you'll see how that came into being later on. I also wrote a book on adventure travel, having done a degree in travel health. Put my wife on the cover, so I can now say I'm married to a cover girl. So we have a lot of partners, as you can see there, and it's just a great privilege to work with the real major global aid agencies and so on, right down to a medical student or a little lady in a church, and we can take their project and project manage it the whole way through to make sure that we deliver the right care. And that's the really key thing. One of the things that I heard mentioned several times is about keeping it simple. And I think I'm a bit of a simple old soul, and that's what I think we do. So, you may now think, Tim, why are you showing me a picture of a car crash in America? Well, it's about the bigger picture, really. You can see how he's hit a crash barrier and landed the right way up. So we can look at that and say, yes, so what? He can go home and have a bit of a stiff drink. But if you stand back from that picture, you see that he landed on the edge of a 300-foot drop. And it's really important, and the thing that we really focus on is making sure we look at the whole picture in a situation. It might be that a surgeon is really obviously keen on his work, but we've got to think about the anaesthetics, the sterilisation, and any equipment that we're sending there, we've actually got to get it there. And we do all sorts of solutions based on the environment we're going to. So it might be a big operating room job, so that we had in for Mercy Ships on the bottom right here. This is for our Rwandan friends. This is in Gahini. It's a new orthopaedic unit for CBM. So you can see we've got a fracture table there to go with the operating table, so they can manage lower limb trauma. Disaster relief. So that's a different scenario. And I was in Nepal. We do have a disaster relief role. I was in Nepal after the earthquake. But then we have more sophisticated units like this paediatric unit in Dar es Salaam, where they had different needs. And so we provided more advanced anaesthetic machine based on the infrastructure that they had. That unit cleared their backlog of advanced cases that needed treating in, I think, 3 months, once we put those 2 operating rooms in. And then finally, something like we've done, to give an example of Syria. We've done loads in Syria, as we'll come on to later on, operating rooms, trauma packs, X-ray and so on. So all of these solutions have got to be bespoke to the environment that they're working in. And I think that's a really big message that I would shout out to you about, making sure the solution that you are creating is a solution that works for the end user, something that's been picked up by previous speakers. One of the things I was asked to talk about was, the sort of obstetric and fistula side in this work. So this is my friend Kez. I can't pronounce his surname if I'm honest. As a leading fistula surgeon, this was an email he sent me. This was about 8 years ago when we sent him equipment for his fistula surgery setup. So we sent him top-of-the-range fistula instruments. We sent him in sterilisation cases. We sent him a manual operating table. Got to tell you, it drives me nuts when I see electric operating tables sent out to the low to middle-income countries because they always break. And you can see what he said here. And to be honest, he also had a light, a battery backup, a mobile light. I'll show you one of those later. But, the thing is, to be honest, this is not rocket science. This is common sense to be able to provide this. And I saw Kez fairly recently, and he said, "So Tim, it's the best thing ever. All my stuff works, and every time there's a power cut, my light stays on." And it's all a case of just supplying a light with a battery backup. I was so pleased that when Professor Jane was speaking to us earlier on, that how he mentioned almost on his first slide at the top about sterility of equipment. I travel to a lot of places, as does my team, and the issue of sterilisation just does not get the airtime that it should. Lots of people supply pressure cooker autoclaves like the one on the left that has been sitting unused for 3 years because no one uses it, has a method of heating it. That's what our EcoClave does. I'm aware of the clock ticking, but I'll just show you this short BBC film on this because it's
called an EcoClave, and frankly, it isn't much to look at. But in a disaster zone or in rural areas in the developing world, its inventor, Tim Beacon, believes it could be brilliant. The EcoClave sterilises surgical instruments, and in Africa, where Tim's medical charity does most of its work, sterilisation isn't always a priority.
In these environments, instruments and other surgical items are not sterilised between patients. On a good day, you may get them put in boiling water. Otherwise, they might just be washed under a tap.
In this country, all our big hospitals, like here at the Norfolk and Norwich, have multi-million-pound sterile services departments. Robots, computers, all the latest kit. In Africa, it's different, of course. And Tim Beacon believes the EcoClave can supply a low-tech solution. It doesn't use electricity, just wood. The instruments go into a pressure cooker, the fire heats it up, and steam does the rest.
Other doctors and healthcare personnel who work regularly in these environments regard it as a potential to be a global game changer. Because not only will you be sterilising instruments, but it's about promoting good practice.
Tim's charity, based near Bedford, provides a variety of medical solutions to the developing world. It refurbishes pre-owned equipment, for instance. The EcoClave sells for just short of £4,000, but frustratingly, it hasn't yet had the impact it might.
Sterilisation is not a subject that is trendy, for want of a better phrase. Obviously, malaria is, HIV, and quite rightly they get a lot of attention. But the whole area of surgery, in fact, in the developing world is not really considered, and yet it is a massive, massive need.
The EcoClave takes about 20 minutes to do its job. It's simple and effective, but not trendy, perhaps. Sterilisation isn't trendy, but Tim Beacon says his invention will save lives. Mike Liggins, BBC Look East, Bedford.
So that kind of says it all about that. But it is really interesting in my role, as I talk to so many NGOs and so on, how little airtime this gets. And it is interesting when we look at data where things like the EcoClave are being used, how the infection rates are absolutely plummeting. Likewise, we've got electrical autoclaves that we supply as well. No circuit boards in them, all designed specifically for the environment. And there are so many broken Western autoclaves in low to middle income countries that should not be there. So it's about supplying the right equipment. And you can see this is just one quote. I've got to move things on because I'm aware that the clock is ticking. But helping to make a difference is straightforward, and again, my message here is to keep it simple. So this is a role play in a disaster relief setup. This is the same setup, in a clinic on the Malawi-Tanzanian border. Drawer-over anaesthetic machine, mobile light, battery operated as well as mains, LED bulbs, and then the same setup in a remote clinic in the DRC, doesn't have electricity, runs off a generator. In their first week, they did 10 C-sections. Just think that's potentially those ladies may or may not possibly have died. They may have ended up with obstetric fistula, and certainly the babies may have died. These people know how to do their job, and I think we can do, I mean, it's quite right we do sort of needs assessments and all these other things, but sometimes as well we've just got to get the kit in there based on current relationships because they can use it. This is manual operating table, nothing sophisticated, but it means they're now delivering great surgical care. The anaesthesia, we've got to address the anaesthesia. There's so many fantastic solutions. The drawer-over machine, the one at the top there, that was all-in-one machine that will run for 12 hours with no power. And when we supply them, you've got to think of the details. So we always supply with an airway box, laryngoscopes, a stock of ET tubes, difficult intubation equipment. There's devices like these in the middle where you can literally fill your own suction bottle, oxygen cylinders up. So we just supplied 5 of those out to some clinics in Malawi. So they have electricity sort of 2 hours a day, so they can basically fill up their own oxygen reservoirs, so they have oxygen for their patients when there's no power. And it's about attention to detail. So these are kind of my hints and tips for doing this type of work. You know, it's about maintaining close communication with your stakeholders. It's the people you're working with, the relationships. So the reason I've got, and defining the objectives. Always assume, I'm obsessed with things not having any power and everything working when there isn't, and any power and minimal maintenance. So this trauma kit, this is what we sent thousands of these to Syria. I had long and involved discussions with the UK surgeons about what they wanted. Some I agreed with, some I didn't, but at the end of the day, we had the discussions and they made the call. We actually saved them £250,000 through our buying procurement model on that. It always is amazing. People forget that the patient range when you do this job is neonate to adult, and we always send 2 of everything in terms of monitoring and so on. We do this work. And everything's reusable suction bottles, reusable diathermy plates, so on. You know, funds are always limited, we know that, or budgets are always limited, but there are funds out there. Sometimes you just got to go and do the fundraising dues, and you've got to also think laterally when you do this work. Lots of options. So this is actually in another theatre that's in the General Theatre in Gahini, our operating table. We supply pre-owned ones and new ones. The point is it's manual, and when we supply it, it comes with lithotomy poles, arm board, and 2 arm table and 2 arm boards. So it's ready to go. Fistula surgery, get shoulder supports. My point is, time and time and time again, I see operating tables sent that are electric and that shouldn't have any, and with no attachments. So it's about thinking about it properly, and really that's kind of my permanent message about our mindset that I'm trying to say. For the fistula surgery, there's a great fistula charity. We've just sent out 28 fistula sets with Western instrumentation. You know, so they raised the funds so that we could do it. And there are, as I say, funds out there. And they go in sterilisation cases. Fantastic little head torches. They're actually rescue head torches at £80, which is a lot cheaper than 2,000, and they're absolutely brilliant. We've got to do the biomedical engineering, you know, but if we supply the correct equipment, there's far less long-term issues. That's obvious, isn't it? We get lots of donations, and we probably chuck away 30% of the equipment. And I've seen equipment sent to low to middle income countries that I would have thrown away. Some of this other stuff here I've just said about. And for our biomedical engineers, they need training, but they need tools and test equipment with some knowledge, and then you just get this fantastic result where you get equipment working and patients having a better outcome. We've now created actually an online biomedical engineering course, launches on the 1st of October. There's details on our website, and one of the units is up for you to look at. And I'm coming towards the end now. But we mustn't forget, you know, there's these difficult cases, the trauma that we've been talking about earlier, they can all be fixed. And sometimes I'm saying to people, look back to the big picture thing. Yes, you've got a great fistula unit, but don't forget, we can still do laparotomies. We can still fix fractures in this place because there's still going to be a need. And this is just a great case history to show what can be done. This is a 3-week-old fracture. We debrided it, put cheap X-Fix on. I can get X-Fix for about £35. The equivalent in the West is about 3,000. And we treated this lad now, gave him a spinal which didn't work, so we had to GA him, which just goes to show you need to have some sort of GA capability. We saved his leg, but the great news is we then lengthened his leg, and that was the result. My point is, it's a nice case to show, but we can do this stuff in country, and we have capable people. Ongoing challenges. X-ray is always a big problem, but now we've got digital X-ray, which is transformational. A mobile machine, digital X-ray, and the mobile machine can be used in the OR, it can be used on the wards, everywhere. And of course, you can send images around the world for an opinion. We do information books now on equipping these environments to help people. And we've created our own surgical preparation list as a lesson plan and also to go up in ORs. So we're trying to change practice based on our relationships. We've got a biomedical engineering app so we can bring in data on what's going in on the ground. So there's lots of things that we as an organisation do, but it's about taking the keep it simple picture, really. And my last slide is this one. Great project we did for Rotary, based from the team in Leicester. They had a massive fundraising effort to raise the money. And I think that what I'm trying to say is there is money around. You, me, we can make it stretch, but there is money around. And sometimes kind of that's the way we've got to approach it. Not try to get it free, but raise some money. That was a very quick journey through. Hope there was some take home in that. So thank you very much.
Thanks very much, Tim. That's very encouraging to hear your work. We are really tight with time, and we've got Prof. Weiser joining in at 2:30 as well. So we'll take one question from the hall, one question from Rwanda, and then we'll have our oral presentees ready. We'll get you to do the oral presentations and then have a Q&A session after Prof. Weiser's talk, which will be at 2:30. Yeah.
So we'll go to Rwanda first, please.
Yes, thank you so much for the presentation. Can you hear me?
Yeah, thank you. Yeah, that's great. Yeah, I can hear you. Thank you.
Thank you for the donation. Yeah, I'm saying that great for the donation you're giving one of our centers here in Rwanda. My question actually goes to the routines, is that we actually get different donations in terms of materials, can be CT scans, can be MRI, but we find out that the material is not going to be working for so long just because there's one thing that is not working, and then we have to outsource the person to come and fix it, of which is going to be a problem, and then we find out that the machine sort of like is out of work the same time that is actually working. So I'm asking in your context, do you also capacitate the medical engineers, or how you do it actually to make it work and do not like offer a donation or something that is actually not going to be benefiting the community? Thank you.
So as I understood it, you were saying about having CT and MRI scanners being installed but them not working. Was that essentially what the question was and how to deal with it?
I'm saying that No, well, my question is actually that some of the time we get a donation of a different equipment, but we are not having any person on the ground able to fix anything that technically that might rise. You know, let's say we have an MRI, at some point it's not working,
sure.
So we are going to be like, but we don't have like person who's able to fix that thing like on a regular basis. So the country or the hospital has to outsource that person to come from abroad to just fix something
I think that
probably was not even like that much of a big thing.
So sure, thanks for that. I totally get your question and understand what you're saying. And certainly, I think there's several answers to that. And I'm not trying to take a slightly third-party view, but a lot of when you're choosing equipment, what should happen is there is a sensible discussion so that you get the right equipment. And the majority of, if you like, traditional OR equipment, the users on the ground, potentially with support from wherever it's been supplied, should be able to sort it out, whether it's an operating table or an anaesthetic machine. When you start to get to the more sort of complex items like MRI and CTs, maybe an X-ray suite, then certainly part of the agreement should be that they come out and install it and maintain it and stay in touch to make sure that that happens. One of the big issues that you have to watch, and I have to say this, is that sometimes donations potentially can be driven by marketing departments who need a quick fix. And you need to make sure you have put, and once they've sent it and got their pictures, that sounds a bit cynical, then you lose the interest. And you have to really make sure that when you get equipment, that the people supporting it are going to support it. We go out and do major installations, but often, like the DRC, we can't get in there, but they're quite capable of setting everything up. So it's back to what I said on one of my slides, communication. But it's also about, actually, something I've not really had time to touch on, donor management, really, and the people, making sure you manage their people who are trying to help use enthusiasm to help with the practicalities of the work on the ground. So it's about really communication and also being quite firm about what you will or won't accept in terms of donations and what you need in terms of support.
Thank you very much, Tim. I'm afraid we haven't got time for any more questions, but the burning questions here, please collar Tim at the coffee break. I'm sure he'll be glad to answer your questions. Thanks very much.
We've had lots of really high-quality abstracts, so we've got some brilliant oral presentations which were very difficult to pick because we had so many abstracts. If you can all come to the front, so you can come quite quickly for your presentation. We've got a 5-minute deadline, and we'll be quite strict on that. So when you hear the beep, which you can't really hear very well, we'll find an alarm for you.
I'll let you know.
Yeah. So if James Chandler can come to the front for your presentation, that would be brilliant.
There he is.
Oh, brilliant. Ahead of the game. Fine.
Say a big thank you to the organisers for giving me the opportunity to speak today. It's a real privilege to speak in front of so many people from different backgrounds, different disciplines, and I hope that we can all help to learn something from each other. So my talk is around a digitally driven fabrication approach for our low-cost gastroscope handle. As a little bit of background, gastric cancer is particularly problematic because it has such a high incidence rate and high mortality rate. On top of that, there's also this geographic distribution that isn't even. So in certain areas, it's particularly prevalent and causes a lot of problem. And often those are in rural areas where there isn't access to suitable screening programs. The good news is that with the implementation of an appropriate screening program, it is possible to reduce the deaths associated with this disease. And really the issue is that getting the right equipment in the right place, the right cost, and with the right expertise means that we can facilitate more of these screening programs and ultimately save lives. So I'm a research fellow at the Storm Lab in Leeds at the university, and one of the projects we work on is low-cost gastric cancer screening. And this is one of the devices called the Gasoc. Some of you may have seen it in the exhibition. So we have this snake-like backbone handle, and that can be manipulated in 3D space by the user. As they do this, this pressurizes syringes inside the casing, and that ultimately passes this variable pressure down to the tip, which has 3 parallel bellows. And that results in a motion that's corresponding to the input from the user, which is highly intuitive and means that you can control the device very simply. The implementation that we kind of envisage for this, or at least one of the versions, would be to have this sterile disposable section which contains the camera, the bellows and the catheter, and connect that to a reusable handle. And once assembled, the device is ready to be implemented in practice. The problem with this really is that this handle design at the moment relies on professional, bespoke manufacturing techniques, machining and specialist 3D printing, along with standard components and adhesives in order to get a functional design. So with this study, we're really interested in trying to simplify the design, but more make it so that it can be produced using simple fabrication techniques. And this is something that Professor Dankelman was talking about a bit earlier. So in this case, we wanted to look at 3D printing or laser cutting technology. And the idea being, if we have a design, we can send this digital file to the hospital and it can be made as needed, when needed, and updated accordingly. So just as there's a shortage of time, two of the example approaches, so one for laser cutting. Here we looked at the chassis of the device and if we could redesign into a very simple way. And here we end up with a 2D cutting plan. This cuts out in a couple of minutes and then can be stacked together in order to create a rigid structure that can support the syringes as well as the backbone handle. And you can see it working suitably there. On the other side of things, we looked at the backbone handle itself, which is probably the most complex structure within the whole of the device. In this case, we tried to use FDM printing, which is the most commonly available around the world. And by creating these stackable disk units, we're able to make them quickly, very cheaply, and assemble a device that has comparable functionality to our kind of best design approach that we can do with access to any kind of machining. So in summary, we addressed two different opportunities, so laser cutting and 3D printing, and there's pros and cons to each, but in both cases we saw a significant reduction in cost and assembly time associated with the design that we're trying to implement. It's really important to consider the kind of characteristics of the design you're trying to achieve and the limitations of the fabrication technique you're going to use. These things will change over time, and ultimately I believe that they can be used effectively so that we can create devices as needed and when needed in a cost-effective way. So thank you very much for listening, and I hope this is a useful talk.
It's really interesting. So if Matthew Doe can come up for the second presentation, we'll have questions and answers with all our oral presenters at the end.
Hi everyone, my name is Matthew Doe and I'm excuse me, a surgical registrar working in the southwest deanery in and around Bristol. But it's a pleasure to be here today to talk to you about my project that I did in Uganda while I was there for a year on out-of-programme experience in Mbale, which I did alongside Professor Achama, a gastroenterologist from Kampala, looking at endoscopy and its provision across the country. So by way of background, Uganda is a low-income country in East Africa with a population of about 42 million. It's 162nd on the Human Development Index and has an annual health expenditure of about £35 per person per head every year. Life expectancy is 60 years and your average person lives on less than £2.50 a day below the poverty line. And what about endoscopy in Uganda? Well, gastrointestinal conditions that require formal endoscopic diagnosis, things like esophageal varices, peptic ulcer disease, gastric malignancy, colonic malignancy, are very common in East Africa, and of course they carry an enormous amount of morbidity and mortality. Cancer of the esophagus itself is thought to be the second most common cancer in Uganda, although statistics aren't perfect on that. And published data regarding endoscopy is very much limited to single-centre studies across the country, and to date there's been no assessment of services as a whole until now. So the aim of this project was to explore the current availability and price of endoscopy in Uganda to give an overall idea of services. So the methods were very simple. I found out all of the hospitals that were offering endoscopy in Uganda and identified a clinician representative in each of those hospitals. That representative was then issued a questionnaire of 13 points, and depending on their preference, were emailed, phoned, or in person. We did a questionnaire on staffing availability and pricing. So the results of that were that 13 hospitals in total offer simple diagnostic GI endoscopy of one form and another. 23 endoscopists work in those departments, and centre workload was an enormous range, anywhere from 2 endoscopies a month to 150. 350 upper GI scopes and 60 lower GI scopes occur each month on average across the whole country, which when you think about it is probably less than one for 1 week in a high-income country in one department. And about 5 of those 13 provide therapeutic services, and all but 1 of those are in Kampala itself, the capital. We also noted that only 3 of the 13 hospitals were actively involved in training, and ERCP was only offered in 1 centre, and that was in Kampala itself. outside the private sector, almost all the units rely on donated equipment, and all of them charge. This is non-private hospitals still have to charge, and they charge £22 for an upper GI scope or £28 for a lower GI scope, including the government hospitals where healthcare is normally free. And to put that into perspective, for a Ugandan that was doing all right on a healthy wage, they'd probably earn that in about 2 to 4 weeks. 4 units that I interviewed had active issues with their endoscopy departments and their kit, which meant that their service was compromised at the time. And no units had guidelines or a training framework. So here's a slide for the geographers. As you can see, the darker green represents population density in this map. And really, it's just to point out where the services are. So actually, the vast majority of endoscopists are clustered in Kampala, the capital. We had one small department in Mbale, which I worked in for 10 months. One in Mbarara, and then in Lachor is the main big mission hospital that works. But as you can see, over in the western Uganda, around Fort Portal, and even down the Rwandan border, I think our Rwandan colleagues are listening, they take most of the endoscopies from the Ugandan side. And a slide for the historians. So the first endoscopy occurred in Uganda in Lachor, in a department that opened and stayed open all that time in the 1980s. And Zambia opened in the 1980s, but then closed quickly afterwards and was reopened in 2010. But this slide I really just wanted to put up to illustrate the cluster of departments that have been opening recently. These are private hospitals, all small departments in either Jinja or in and around Kampala. And there's a lot of them opening in the last 5 years, which raises issues with clinical governance and accountability. So in conclusion, this is ultimately the first study of endoscopy availability, cost and service in the whole of Uganda. Access to affordable diagnostic and therapeutic services are improving, but they do remain limited and unreliable. Established services are focused in the capital, Kampala, and unfortunately they're unaffordable completely for the majority of Ugandans. I have to mention the limitations of this study, of course, and ultimately it's qualitative data when we want quantitative data. Okay. Shall I tell you that? I'm sure they want to hear the discussion. Don't you all? Yes. 5-second discussion. There are hardly any other limitations. In terms of discussion, future effort to improve services should focus on full utilisation of existing departments, limiting cost and training more practitioners. New units in populous areas, as I've discussed, should be considered. And most importantly, I think a National Endoscopy Society, which we tried to set up whilst I was there, will provide the ultimate vehicle for service improvement. Thank you very much.
Our next speaker is Ria Sauhini.
Hi everyone, I'm Ria Sawhney. I'm a final year medical student and I'm going to talk to you about the usability of a low-cost laparoscopic trainer called the Lap Pack in training medical students and trainees in low and middle income countries. So as I'm sure we're all aware, laparoscopic surgery is the gold standard treatment for several conditions, mainly due to improved patient outcomes and cost savings. However, barriers such as limited access to the expensive training equipment, etc., have prevented full adoption of laparoscopic surgery across the world. And according to the Lancet Commission, we need 143 million additional surgical procedures every year. And of these, about 1/8 or 18 million could be done laparoscopically. So there's tremendous scope for laparoscopic surgery to be adopted around the world, but it isn't being done. And therefore, there is a need for low-cost laparoscopic trainers, which is why we propose the Lap Pack. This is a modular low-cost laparoscopic trainer. It's made with corrugated plastic and it's compatible with laptops, smartphones, tablets, and it's lightweight, portable, and it's super easy to assemble and disassemble, and it comes in 2 versions and the cost changes accordingly as well. So we did this study as part of my elective in global surgery in New Delhi in India. And we had 10 senior surgeons, 11 junior trainees and 12 medical students participate. We asked them to complete 2 tasks. One was peg transfer and one was precision cutting. And then we asked them to score the Lap Pack in a series of questions. And I'll talk a bit more about the scoring system. So the first one was the face validity criteria. This was developed by the surgeons and the engineers on the team, and it basically comprised of a score of 6 from the criteria you can see on the screen. And then we also asked them to evaluate the lap pack in a series of other categories, which were the usability, camera, views, and material. And some of the individual questions within each category you can see on the screen as well. So the mean face score that we got was 4.62 from a possible score of 6. And it is fairly high, but what we found in our analysis was that if there was one criteria that was holding the score back, it was the ambiguity to do with the one that's highlighted up there, dedicated light source. And that's because the lap pack uses ambient light, so the light that's in a room, for its light source, and doesn't have an explicit light source of its own. So that created some confusion, and some participants did mark it down for not having its own light source when it just had a light source. The other 4 categories then, as you can see, usability was ranked the highest. It scored 6.05 from a possible 7. And all 4 categories did quite well, scoring above 5.1 from a possible 7. Material was ranked the lowest at 5.18, and that's mainly because of the durability. So people questioned whether this corrugated plastic would be durable enough to last a few years. Then we have views coming in right after that at 5.39, and again that's to do with the ambiguity with the light source. As you can see, one of the questions said, is it isolated from ambient light? And it actually utilizes ambient light for its light source. So some of the highest scoring individual criteria you can see on your screen now. So people really seem to love the fact that it was so lightweight and it was mobile, so you could pack it up and take it, use it anywhere. The quality of image and the colour of image was scored really highly as well, and the ease of assembly and disassembly performed really well. So overall, it's been highly scored across evaluation categories. It had mean scores of over 5 in all the individual criteria as well, and mean scores of over 5.1 in the 4 major categories. The slightly lower scores, where there are some, can be attributed to the ambiguity in the questions themselves. And overall, the usability was the highest performing feature, and that is what seems to matter the most. Limitations, of course, it's a quite small sample size, so we're doing a concurrent study in Leeds and we're awaiting some data from that. So we're evaluating the opinions of UK surgeons and students. And there were some issues with compatibility with smartphone apps for the USB camera. So there is a possibility that we'll develop an app for the USB camera to accompany the lap pack as well in the future. It seems to be a very suitable low-cost laparoscopic trainer, and it shows a lot of promise in terms of increasing access to laparoscopic surgery and training in LMICs. Yep. Thank you.
Sergio, who is based in Leeds but is currently in Iceland, will be taking questions later.
You have the speaker on, please.
And I'm from Zimbabwe. Andile Makawe Dube, and I'm from Zimbabwe, and I'll be presenting on our paper, Trends in Ultrasound Scan Use in Low to Mid-Income Countries, a Systematic Review. Ultrasound scan imaging is a preferred means of imaging in global surgery, given that it is both cost-effective and efficient. Its low cost makes it favorable amongst other diagnostic techniques such as MRI and CT scan, and it is also efficient because it is portable. In 1997, the World Health Organization and that had the access, these countries presented barriers that limited the use of the efficient use of ultrasound scan imaging. Despite the potential role that ultrasound imaging has in global surgery as both a diagnostic tool and in clinical surgery, not enough evidence is currently present on trends in its use, and so its impact and cost benefit in low to middle income settings is not adequately measured. The purpose of our study is to determine utility and applicability of ultrasound scan use in low to middle income countries, and in the process we hope to achieve 3 specific aims. Number 1, it is to characterize and evaluate 1, the geographic use and specialty trend use in ultrasound scan imaging. Number 2, to determine the innovative applications of ultrasound scan use in low resource settings. And number 3, to determine, evaluate, and characterize the development of associated educational or training programs in ultrasound scan imaging in low to middle income countries. We use the PRISMA checklist as a guide to our systematic review and researched the databases Medline Ovid, EMBase, and Cochrane Review of Clinical Trials in 3 languages of English, Spanish, and French. We selected studies that were published between 2010 to 2018. Countries were determined as low to middle income countries based on the World Bank categorization of country economies 2018. For study selection, 2 specific categories were used. The first category was studies that were included were those in which ultrasound scan imaging technology was utilized in a clinical medical settings in a low to middle income country. The second category was that studies were selected that had an original ultrasound scan research involving novel application of ultrasound scan technology in low resource settings, those with an education or a training aspect in ultrasound imaging use in low to middle income countries as well. Our results showed 6,276 studies from the search of keywords, and of those, 4,563 studies were included in this review. 332 studies of those contained original or novel applications of ultrasound imaging in low to middle income countries. Most of the study, being close to 70%, came from Southeast Asia and Sub-Saharan Africa, with most studies coming from Egypt, Nigeria, and Pakistan. Our study demonstrates increased use in ultrasound scan imaging in low to middle income countries by nearly 60%. And it also demonstrates an increased geographic use of ultrasound imaging by more than 20%. Specialties that were most represented in these studies to be using ultrasound scan imaging were cardiology, gastroenterology, pediatrics, obstetrics and gynecology, and general surgery. Novel applications of ultrasound technology were used primarily or presumably in screening for obstetric care, infectious disease, cardiology, and abdominal diseases. 23% of original studies had an educational training component to them in ultrasound scan imaging, and most of these studies were conducted in tertiary hospitals. The limitation that we had in this study was the lack of quality data, and amongst the studies that we selected, we had very few randomized controlled trials. The changing classification of low to middle income countries based on the World Bank categorization of low to middle income countries made it difficult to classify countries year by year in the year the study was published, as it always differed every year. The conclusion to our study is therefore that our systematic literature review of ultrasound scan use in low to middle income countries showed growing utilization of this relatively low-cost portable imaging technology in low-resource settings. I will allow questions from my colleague at this time, but from my end in Zimbabwe, thank you so much.
Thanks, Andele and Sergio, if you are watching us. Great presentation.
Do we have Professor Tom Weiser? Yes. So our next speaker is going to be via teleconference. His name is Professor Tom Weiser, who is an associate professor in the Department of Surgery at Stanford University Medical Center. He practices general, emergency and trauma surgery and surgical intensive care. He is also a visiting professor at the University of Edinburgh, working with colleagues at the Royal Infirmary of Edinburgh and the Global Surge Collaborative. He is the clinical advisor for Lifebox, a charity dedicated to improving surgical safety worldwide. And he'll be speaking on the Lifebox project Clean Cut and tackling SSIs in LMICs. Thank you, Professor.
Hi, thanks so much. Can you hear me?
Yes, we can.
Okay, great. And how do I share my slides, or is that something that you do?
You've got a screen on the top where you can share your screen next to the phone.
I see it. Okay.
And then.
So.
Yeah, that's great. Thank you.
You should. Perfect. You should be able to see. Second. Right. Now, you should see the heading screen. Is that correct?
Yeah.
Yes. Perfect. Okay. So thank you very much for inviting me to speak. My name is Tom Weiser. I'm a general and trauma surgeon at Stanford University in California. And I am currently a visiting professor at the University of Edinburgh in Scotland. And I am also the clinical advisor for Lifebox. And the program I'm going to talk to you about in the next 10 minutes is a program that we've developed and deployed and implemented in Ethiopia. It's called Clean Cut, and it's essentially a surgical infection prevention program grounded on the elements of the surgical safety checklist. And for the non-clinicians in the room, the surgical safety checklist is a tool that surgical teams are to use right before they start an operation. So before they start the anesthetic, before they cut skin, and then at the end of the operation, before the team breaks up, you're supposed to use this checklist to make sure that kind of critical components of the perioperative process have been complied with very much prior to takeoff. This is the checklist itself, and the program Clean Cut is founded on these elements of the checklist, particularly those that relate to surgical infection prevention. This is really important because the checklist as a piece of paper is obviously very powerful, and we've already had very strong evidence to support its use. The problem is that it's very difficult to implement, particularly in settings where the processes and the procedures are not well aligned. And so the Clean Cut as a program tried to align the processes, particularly upstream processes, to get best compliance with standards of care. The checklist promotes surgical teamwork and supports behaviors in the operating room to improve communication, to help develop a better relationship between the different teams, the surgeons, the anesthetists, the nurses, and the other members of our team. And as I said, the focus really is on driving down surgical infection rates. So in surgery in general, throughout the world, but particularly in low and middle income countries, surgical infections are a massive cause of excess morbidity and mortality. They can complicate anywhere, depending on the type of operation, from 5% to up to 35 or 40% of all operations. And once a patient develops an infection, they're at much higher risk of death. And there's a number of things that we can do as providers to ensure that the likelihood of infection is reduced. And so simple things like, making sure that the environment is clean and washing our hands and cleaning the surgical site are all critical components. But also there's a number of other elements, and the use of antibiotics and the use of sterile instruments, et cetera, that are all really important to drive down infection rates. This Clean Cut is a checklist-based, team-centered, adaptive approach, trying to kind of decouple and understand how the upstream processes are affecting, are basically affecting outcomes of surgical patients. We focus on 6 core surgical standards, infection prevention standards. These are universal in the operating room anywhere in the world. The appropriate preparation of skin, both the surgeon's hands and the surgical site. The maintenance of a surgical field using sterile gowns and drapes that don't have holes and that are guaranteed to be sterile, as well as the use of sterile gloves. The confirmation and the appropriate decontamination and sterilization of instruments used for surgery. the timing and selection of antibiotics before surgical scan incision. And this is actually a really important part because getting the right dose of antibiotics at the right time is really important because you need appropriate tissue concentrations to destroy to destroy bacteria skin incision. The routine counting of swabs both before and after surgery. So counting your sponges and swabs before surgery doesn't do any good if you don't count them afterwards, and vice versa, to make sure you haven't left any behind. And then finally, the use of a checklist to improve communication and teamwork. What we, during the implementation process, what we did was we measured surgical infections throughout this time period. We also measured hospital length of stay, other infectious complications, the need for a reoperation, or mortality. So in addition to the outcomes that we're measuring to see if whether or not we were changing actual, meaningful results from surgery, we also measured compliance with those 6 core standards. And the way that we did this is through a kind of a process called process mapping. And process mapping is is understanding all the elements and ingredients and steps that it takes to get to some certain result. So when you are making beer, for example, you have all these processes. You have your ingredients, you've got your wheat, your water, and your yeast, and then you have a process by which those ingredients come together in a fermentation tank, a fermenting process that allows for the fermentation of your wheat and your yeast, as well as ensuring that there is no contamination of your samples. Then your storing of the liquid that you have resulted from this process, ultimately resulting in a pint of beer at the end. So there's a fairly rigorous and well-established process for getting from the very, very early ingredients in their natural state to a pint of beer at the end. And surgical and the process of delivering on any promise of routine standards follows that similar process. So this is a process map looking at antibiotics, for example. So the process map basically looks at how does the surgeon make a decision about antibiotics? How is that decision communicated? Where are the antibiotics located? How are they organized? How are they paid for? How are they allocated? Where are they stored? How do you get the antibiotics from their storage place to the bedside? When do you give them? Do you give them up on the ward, or do you give them in the operating room? And then once you're in the operating room, how do you choose the antibiotic? Do you confirm that they've been given? If the operation is a long operation, do you redose them? And then do you decide whether or not to continue antibiotics after the surgery is all done? And so this process, doing a process map like this, starts identifying gaps and weaknesses during the perioperative routine, where there might be gaps, weaknesses, lapses, or poor processes that allow for errors, good compliance. And this program has now been introduced originally in 5 hospitals in Ethiopia. We're now in 3 new hospitals and deploying in 5 more, so 8 more hospitals. And then working with the Ministry of Health now, the plan is to deploy in 28 further hospitals. So we're going from kind of small tests of change to a much wider scale now. And the way we do this is essentially as we kind of create champions, we establish surgical teams, we set up a surveillance system, we produce local process maps to understand what the local process is. We identify where those barriers exist, and then we have the teams on the ground, the Ethiopian clinicians who are working in place, identify their barriers, identify local solutions. We're now in the process of codifying this into a playbook and with a lot of tools, writing up case studies and have done some qualitative evaluations about how this is received by the different providers. and we're now expanding over the next year or two in conjunction with the Ministry of Health. These are results that were presented about a year and a half ago from some of the early results of our first set of hospitals. So very, very quickly, once you start identifying where the problems are in the process, you get a very rapid improvement in compliance with best standards. So, for example, dramatic improvements in appropriate hand washing, dramatic improvements in how you identify and flag gowns and drapes that have holes in them for repair. dramatic improvements in the timing of antibiotic administration, dramatic improvements in the routine counting of swabs because of appropriate training and appropriate kind of care routines. And all of these kind of improvements in processes can kind of be plotted on what we call a radar plot or a spider plot that you see here. And perfect compliance is defined by that outer edge of the radar plot. And what you can see is in blue is where we started with in our 5 hospitals. But then over time, as we improved the processes, we got better and better compliance with each one of those standards that I discussed and introduced earlier. What that's related to has been dramatic improvements in infections over the course of the program. So we have about 2,200 patients, and we've been able to drive surgical infection rates down by 35 to 45%, which is really, really powerful when it comes to demonstrating the effect of the program and getting the buy-in of the ministry and the providers. So now we're looking for partners to implement both within Ethiopia and beyond, and we're spreading it to other contexts, including India, likely Rwanda, and maybe a couple of other countries within the next year or two. As I said, I'm the clinical advisor for Lifebox. This is our website. Lifebox is a charity based in the UK devoted to improving surgical safety and saving lives through safer surgery. And I believe I have 5 minutes or so for questions.
Thank you, Professor. Do we have any questions from the floor?
So since I can't see anybody, someone will have to moderate and repeat the question. If there are any.
No question.
Can I ask a question, please?
Yes.
Oh, thanks. So here in Leeds, Professor, we've got an example of a wood-fired autoclave. Can you just tell us a bit about the sterilisation as part of your package, please? How that was undertaken?
So it was around how do we, what's one of those items is around ensuring the sterility of instruments. So this is actually probably one of the most complex processes because it requires a fairly robust system on the upstream side. So we don't purchase new autoclaves or allocate resources for any of these processes that are currently not working. And autoclaves are a big issue. But almost every place that is doing surgery has an autoclave of varying functionality. Some autoclaves clearly are not functioning at all. Some autoclaves function very well, and some people believe are functioning very well, but there's no guarantee of whether or not the autoclave is actually delivering a sterile set of instruments at the end. And so we've done a fair amount of work in conjunction with another charity called Spec Trust, helping train the cleaners, the operating room cleaners. So these people tend to be, not even nurses. These are usually the kind of janitorial staff of the hospital, and giving them training on how to clean, decontaminate, and process and set up surgical instruments has been a huge boon to a lot of hospitals because almost none of these folks have ever had formal training. We've had a number of places where the autoclave hasn't worked, where we will bring a biomedical engineer from one hospital and have them, so when we'll do a site visit, we'll have a biomedical engineer from one hospital come with us on a site visit to another hospital and fix a different hospital's autoclave. That's been a huge boon. The interesting thing is that hasn't required any resources on our part, right? These are just using local together so they are bring for facilities and systems. The autoclave has been, I know this is kind of a hackathon, and everyone always focuses on the autoclave. The autoclave is a really, really difficult piece to sort out. It requires a lot of energy, very to do in order to process instruments at the scale that you need to do for a busy operating room. I mean, there's lots of kind of boiling of instruments or putting them in pressure cookers, but those don't get you really super quick turnover of large amounts of sterile instruments.
Thank you.
Thank you. I think we might have a question from Joseph, possibly in Rwanda. Joseph, can you hear us?
Yes.
Do we have a question
sure,
from
I can hear you very well. My
Yes, I
question
can hear you.
is, what are the measures you put in place for follow-up of equipment you give in the RMICs? You do a great job, but what is the follow-up of those equipment? Thank you very much.
So the question is really around the follow-up of the equipment. So I think there's two questions in there. So the first question is around the kind of the immediate follow-up. So how are instruments kind of processed, sterilized, and then ensure that they're sterile? And then the second question may be around how do you maintain instruments? So what happens to scissors that are dull? What happens to forceps whose tips don't work? What happens to, how do you maintain instruments that are used and kind of get dented or dulled over time? So for the first question, a lot of places will have the external sterile tape that gives a marking of whether or not the autoclave worked on the outside. What we'll frequently do is we encourage the cleaners who assemble the tray to fold a piece of tape and put it onto the inside of the tray as well, so that we know that the heat is reaching the inside of the tray. And that's one of the ways, at least kind of in a very low budget way, that we're assuring at least that the heat is reaching a temperature inside the tray that reaches kind of normal sterilization temperatures. It's not totally reliable, but it's better than what's frequently available, and it's a lot less expensive than having kind of the more sophisticated, very expensive kind of metallic indicators that are disposable that are frequently used in places like the UK and the US. So that's the first thing around ensuring that the instruments that go through the process are actually sterile. The second question really about how do you maintain instruments with respect to instruments that are dull or blunt or no longer work is really tricky. We have worked with metal workers so that local metal workers can help start learning how to fix instruments. It's a really, really tricky problem because the quality of the instruments is very variable. There are some instruments that are very, very high quality. Those are usually made in places like Germany. There are also instruments that are very, very low quality. Those are usually places that are made in like South Asia or Southeast Asia, and then they don't go through a kind of secondary quality control. And those instruments are much, much harder to repair because they're much more brittle, and they're not really made for repairing. So that's just a really tricky problem to solve, and it's not something that we've been able to solve entirely.
Perfect. Thank you, Professor. What a great talk. And I think that's it in terms of questions for the Professor. Thank you. Round of applause, please.
Thanks very much, Professor. It really sets the scene for the upcoming hackathon that's happening in the next 20 minutes or so. So we really appreciate for you to come and share your thoughts. It's been very useful. Thank you very much, and really appreciate the work that Lifebox is doing, and Gasoc really wants to continue the support for these organizations. So thank you very much.
Well, thank you very much. I appreciate it.
Thank you. Bye-bye. Okay, so we are now going to have about 7 to 10 minutes Q&A for the speakers. So the guys, Matt, James, and Ria. So if you want to just come on the stage, and we'll just open up to the room and Rwanda to ask questions. And we've got Sergio from Iceland. Sergio, can you hear us?
Yes, I can hear you.
Excellent. So for Andile's presentation, Sergio has been a part of the project. So if you have specific questions for Sergio, you can ask him that question as well. We'll just need to stick to time, but we've got about 7 to 10 minutes.
How many
Okay.
do you need? 4.
So any questions for the presenters? Some great presentations, folks. I can't see anything. Is there? Oh, a question right at the top over there. I can't reach you with the mic.
So shall I just project? Is that good enough?
Yes.
I have a question for Matt, if that's all right. So I think, well, thank you so much for your talk. It was really interesting to see the approach that you took to figuring out what the state was in Uganda. I'm just interested to know what platforms you shared these results on in Uganda itself and what came on from that in country. Because obviously it's difficult to, choosing the right platform to share research findings is probably like a really important consideration.
Yeah, 100%. Thank you. So the main idea that you might have caught at the end was to set up a national endoscopy society, because it became very clear when I arrived. So a bit of a long answer, I apologise, but when I arrived in Mbale, there were 2 endoscopists doing about 20 endoscopies a month. One of them quickly left. The other left about 4 months into my time there, so I was on my own. And then I was just interested in who else was doing what. We didn't do therapeutic endoscopy. I didn't know what to do with patients with esophageal varices, etc., where to send them for intervention. So I identified Professor Achama in Kampala. I was linked up with him. He he trained most of the endoscopists in Uganda himself, so that was the way I identified everyone else. And then the plan was just to ask questions, turn it into a bit more of a formal study, and then present the findings at a national meeting specifically designed for endoscopy. And I was going to mention this earlier, actually, in response to the question about companies holding low middle-income countries slightly at ransom for what they can offer, because alongside Prof. Achama, he's head of the Ugandan Gastroenterology Society, which agreed in a meeting with myself and 4 or 5 of them in Kampala that we'd set up an arm of the Gastroenterology Society that would be an endoscopy interest group. From that, there would be guidelines and a training program that would come out of it. We made a conference, we had a date, we had a sponsor. That sponsor was a provider of endoscopy equipment in Uganda and had provided it for most of those private centres in the months and years before. It was all lined up, and then they pulled out a month before the conference was about to happen. So all of this exciting work trying to formalise a national endoscopy process in Uganda kind of fell to nothing. It won't disappear, we'll try again, but it was frustrating. So unfortunately I didn't present it in any proper meetings, because the meeting that was supposed to happen never did.
Thank you for that. Do we have any questions for Sergio?
Hello. Hi, Sergio. Congratulations on an absolutely huge systematic review with 4,000 included papers. But I wanted you to explain to us why you surveyed the literature in this fashion. What did you feel was to be added by collating academic activity in ultrasound use?
Yeah, the idea was originally conceived in talking with Professor Chris Lobby at the Oxford group, Global Surgery Group, and we think that ultrasound is a affordable and portable technology that can be used in a lot of different settings. It's easier to recharge and to transport than a lot of other imaging technologies. And so while there's been a lot of progress in implementation of new technologies using ultrasound in new protocols, especially in the US and the United Kingdom, for a variety of different purposes, we wanted to see if there was a way to assess uptake in lower and middle income countries, LMICs, as well as show that there's actually a lot of very novel applications of ultrasound that are being studied and developed for problems in LMICs. And so the studies that we saw in Nigeria, India, as well as Southeast Asia and Africa, whether looking at schistomyosis or looking at treatment of clubfoot using ultrasound, that we wanted to be able to quantify and show that there's actually a real need for primary research in novel application of ultrasound that's being developed in LMICs for issues that are identified in those areas. At the same time, there's a lot of uptake in application of those technologies that have already been determined and assessed in places like the United States or the United Kingdom.
Thank you, Sergey. Any other questions on the floor?
Hi, thank you very much for all of your talks. I just had a question about 3D printing. Forgive me for being ignorant, but I just wanted to know a bit more about 3D printing and what role you see that having in the future of development for the use in LMICs. Thanks.
Thank you very much for the question. So the thing with 3D printing is that there's many different kind of incarnations of it, so it's kind of a catch-all term, but the good thing and the thing we tried to tackle on this approach was that FDM-based 3D printing, which is extrusion of plastics, is probably the most common one and the one you'll come across in any kind of media coverage. That's very prevalent. There's a huge open source community. Kits are available from as low as £100 or so up to a few £1,000s. So it's widely accessible, and we kind of wanted to constrain ourselves to utilising that technology. And that's not to say that the output right now is going to be perfect and to the extent that it needs to be to produce suitable medical devices now, but as things progress, as more materials and processes for making sure those materials are sterile, for example, come into place, we could see that many devices that are currently out there could be redesigned to be suitable for production in this method, which would be a huge benefit in terms of reducing kind of the logistical burden, the risks of not being able to get access to parts, as well as being able to iterate faster, so the design can change very rapidly. I hope that kind of covers some of the question.
Any other questions? Can't see any more. Oh, there we go.
I've got one for Ria. So you did a brilliant presentation on the usability of the simulators in LMICs. How do you see its role and the setup of a general kind of training pathway for laparoscopic surgery in those settings?
So the way it was meant to be used was basically... Thank you. So the way it was meant to be used was basically to make sure hospitals across LMICs have access to a training tool. So even without the establishment of a national sort of training programme or pathway as such, they have access to be taught even when, say, visiting surgeons go on and stuff. And while that's not sustainable in the long term, and you would hope for a national level change and a change on a higher scale, it's always better to, I guess, start with something small and then work your way up rather than hope for a bigger change that never really comes across.
Brilliant.
Great, thank you.
Thank you to all of our presenters. I think we're going to move on to a few presentations or videos now. So a round of applause.
So we are now sort of slowly moving towards the hackathon, and we'll have the director of MedTech Foundation, Dr. Will Bolton, come and speak. But Prof. Weiser's talk definitely sets the scene. And I've got sort of two real examples of an anaesthetist based in Rwanda, who is live streaming right now, Joseph, who is going to talk a little bit about sort of, his experience with surgical sepsis in his country. And then one of the rural surgeons that the Leeds group works with has also created a 2-minute video, and he talks about his perspective from a sepsis point of view, and that sort of nicely takes us into Dr. Bolton's talk. So we'll start with Joseph's video here. There he is. I hope the speakers are working okay.
Hello everyone, I'm Dr. Joseph Nitegeka. I'm an anesthesia resident in the University of Rwanda. I'm going to talk about challenges in management of sepsis in RMICs. As you know, sepsis is a big challenge because we are losing many of our patients. In RMICs, you may have mortality which can go up to 80%. So, the first challenge is the knowledge gap. People don't know about sepsis, the pathophysiology, the management, appropriate medications, so how to support those patients. So another issue is equipment. So we don't have equipment to diagnose quickly sepsis. Most of our staff or people really rely on a clinic. But also, as you know, we have also to know what is the germ is causing the problem. So we need the antibiogram, we need the other test to know if there is no damages for other organ or systems. We have also problems with monitoring. So we need equipment, we need equipment mostly in the ICU in our wards so that we can follow up and make sure we know that there is any change in our patients. We have also another problem of systemic issue, which include transfer. So there is big delay for our patient to present it to appropriate staff so that they can come and get appropriate medications and management on time. There is also procurement problem. The procurement process is a very big gap because it leads to delays, unnecessary delays, mostly for getting equipment, medication, and so on. Another challenge we have is medication. As you know, we are facing antimicrobial resistance, which is going up, and we are remaining with medications which are very expensive and are not available in our countries. And if they are available, they are very expensive. Those are our big challenges. Thank you very much.
Thanks very much, Joseph. When I saw this video, I just felt that I was in Rwanda, in Kigali, with Joseph. You can hear the kids at the back and the beautiful backdrop. So hopefully one day a visit is planned to Kigali. Is that okay, Joseph?
Yeah, that's okay.
Okay.
That's it.
Okay, so we've got Dr. Biju Isleri here, who is a rural surgeon in Assam, and he's one of our surgeons we've trained to do gasless laparoscopy, and he's going to talk a little bit about sepsis as well. I hope his video works.
Hi, I am Dr. Biju Isleri. I am a general surgeon working here in a small hospital called Crofts Memorial Hospital in Chirang district of Assam, state of India. Just a few lines talking about surgical sepsis. What I face here in this rural setup is there are two groups which I have found, some coming early presentations of with sepsis, with different source. The sources may be appendix, gallbladder, gynecological related sepsis, urosepsis. These are the common conditions which I find here. And they are treated, and those requiring surgeries, we do surgery on them and then they recover. But there's another group of people who are coming with the late presentations of sepsis, and those, most of them are related to diabetes. The sources are the same, like appendix, gallbladder, or urosepsis, or gynec-related sepsis. These are the common causes which I have found. And because of this, the late presentations, they're having hypotension, in septicemia and septic shock. So those are the group of patients which we are not able to handle here, since we do not, we lack in infrastructures, we lack in staff, and hence, when we try to refer them to higher centers for further treatment, they are not able to go. The reason is that they are from very poor socioeconomic status, and they usually succumb to the disease, and we are unable to save them. This is how the serious problem that we are facing here to treat septic shock and septic patients. Thank you.
Excellent. Thank you very much, Biju, if you're watching us from Assam. Okay, so we'll have Dr. Bolton come up and introduce him, please.
Dr. William Bolton is an academic foundation trainee and NIHR clinical research fellow in the Global Health Research Group, Surgical Technologies in Leeds, UK. He's taking time out of programme to complete his PhD, exploring surgical technologies for application in low and middle income countries. His research interests include the development and evaluation of novel surgical technologies, its application to low resource settings, and clinical trials design in global surgery. He's a board member of the NIHR Surgical MedTech Cooperative, and he's a director, co-founder of the student and trainee-led group, the MedTech Foundation. Dr. Bolton will explain the concepts of the hackathon, which can lead to a solution to reduce surgery-related
Okay, thank you very much. That was
sepsis.
That was incredible. That's my entire CV right there. So it's very warm, and we've been sat down for a long time full of lunch. So just really quickly, can we all just stand up and just spin around a few times? Okay, be careful, don't fall over. And then have a bit of a stretch, and then sit down when you're ready. Okay. Yeah. I can see some people doing some squats and lunges at the back still. You can probably stop now. Okay, so I hope that gets you all really pumped for the next stage, which is the hackathon. I'm Will, and you've heard literally all about me. This is Hira, and she can do a better job of introducing herself in a moment, but she is one of my colleagues. So I just want to say a huge congratulations to Noel and Sarah and the rest of the team here. It's a huge task to put on something like this. It's absolutely fantastic to see a broad range of people here in Leeds, but also Skyping in. So please follow me on Twitter, because I don't have very many friends, so it'd be great for you to follow me. And I'm just going to quickly introduce the idea of a hackathon, and then here we'll tell you about what we do here with students. So I'm not going to repeat this in too much detail, but you all know what universal health coverage is. And in the Lancet Commission on Global Surgery, they highlighted that technology is going to be a key driver to achieve universal health coverage. And surgery is one of the most technology-dependent specialties, as well as anaesthesia and obstetrics and affiliated specialties. And we're obviously very lucky to have the NHS. Not quite sure why that's there, but I just thought it would be really good to go back to basics and just think about what a technology is, because a hack, you're going to hopefully come up with tons of really good ideas. They don't all have to be technology-based, but ultimately, in my opinion, technology is just a tool that allows you to achieve something. So on the far side, we've got quite simple technologies all the way through to abilities to put people to sleep and operate on them, but also technologies to manage the healthcare finance and virtual reality technologies to train surgeons, for example. And we have this technology evolution which is happening, and as I said, I think the Commission really highlighted that as a key driver. Important to understand what innovation is as well, because we all use the term innovation. It's one of the key terms, and it all means different to different people. But I think in the purpose of the hackathon, an innovation is literally doing something new. As long as it's new, it could be in a new population or with a new, with a new context in disease area. As long as it's new and it increases value, then I'm happy with that. That's what I would consider as innovation. The problem is in innovation in healthcare is it's often very slow, and the reason for that is rightly we don't want to just practice innovating and experimenting on patients and killing loads of people, but we also have a duty to innovate and come up with new ideas. So there's a couple of ways that I hope throughout this hackathon you'll understand how we might be able to increase innovation in healthcare. The trainee bulletin from the Royal College of Surgeons, there should be a copy given to you, but if you go to page 24, there's an excellent article which I was one of the authors on, and it showed in it we reported that around only 1% of all ideas actually make it to widespread adoption. So that means that you need tons of ideas to start with, and you need a way of filtering them out to actually get them to the one that's going to be adopted and success. There's also a huge medtech skills gap. You know, most of us are clinicians here, but at uni we never get taught how to innovate in medtech or innovate in any context. We just get taught how to read books and answer big exam questions. So there's an important need to actually do some of this training. So I'm really grateful for the opportunity to be here to do that today, hopefully. This might not be new to you, but I think it's really I'm not going to go through the pipeline in detail, but I think it's really important to understand the translation pipeline, because you could plug in almost any idea at the start from bench, and it has to go through the evidence generation, entry into a market, and dissemination. So that's a key principle to understand. Really importantly is interdisciplinary collaboration, so collaborating with people from different specialties. And I just named these ones up here as the key sort of players in a medtech project. And just one example of that is the gasless lift device that we've been talking about. It's out there on one of the stands. So this is to facilitate laparoscopic surgery in developing countries. So just as a case example, we have academics and scientists from our engineering departments here that are doing all the mechanical testing and the manufacturing testing. We have governments and policy, so we have people from big advocacy groups and ministries of health involved in this. Obviously healthcare professionals and surgeons, and really importantly industry. And people are often, well, particularly clinicians I suppose, are quite, some in the NHS at least, are worried about working with industry because they think they're going to steal their ideas and make loads of money and kill all the poor people. But that's actually not what happens. First of all companies have something called corporate responsibility, so they all have to do good stuff, and it looks really good on their sort of PR campaigns and all the rest of it. But you have to be able to articulate the advantage of working with a company. So, for example, the group that's working with us on the lift device is a company called PDM, and a couple of the members are here today. They're a Yorkshire-based company. But we were able to articulate the benefits of working with an academic group. So they get access to all kinds of engineers and scientists and surgeons. They get University of Leeds affiliation and all the rest of it. But you have to be able to articulate it. And then in that case, then you'll get a lot of help in kind. It won't cost you as much, and everything will be developed in a nice collaborative way. So really do work with each other. We've heard about frugal innovation from Prof. Jane, who's my boss, and I have a significant man crush on. So I always like to mention frugal innovation, which is one of his favourite topics at the moment. And as he said, it is to do more and better with less. And some of the key principles that I think we should probably try and think about as we're hacking today is keep the user in mind and make sure that we've got a user-centred design of whatever we're thinking about. No sort of bells and whistles. So we're not saying that it needs to have like crap functions or it's made out of rubbish material, but it just needs to have the core minimum required functions to solve whatever the problem is. And I've said that twice. So minimum specifications and core functions are obviously really important. This is the sort of highlight that we're talking about frugal innovation, but it's also something called disruptive innovation, which is a bit like Uber. So Uber's a disruptive innovation in that completely alter the market. So try and think laterally. Rather than making loads of taxi drivers, why don't you make an app to connect them all or whatever? So that was just an example. What we can see in disseminating a technology is you need to have the evidence base, which is the research. You need to understand the process of the technology, which is a bit what Prof. Weiser was talking about, and obviously the collaboration with different disciplines. So finally, we're on to hackathon. Has anyone participated in a hackathon before? Okay, a few people. Okay, perfect. I know you have, Dr. Ganamaj. We've done one together. Essentially, it's an iterative solution-generating exercise, which is a fancy way of saying just talk about loads of cool ideas as fast as you can. Okay? The idea is it gets lots of people from different specialties into the room with different skills, but they all focus on the same problem. It's collaborative. It's going to be really intense because we're really running sort of short on time, but it's hopefully really effective as well. So just a couple of quick examples. The NHS is really difficult to navigate, even for someone who's English first language and has lived here all their life. It's really difficult to find out where to go. So they did a hackathon and they came up with an app to improve the navigation for people who English might not be their first language and so on, and that's been really successful. If anyone works in the NHS, I guess most of you are, the IT is absolutely dreadful, and none of it talks to each other, and in Bradford we still use fax machines. So they did a hackathon to try and make IT less bad. Note that it wasn't to make it good, it was just to make it less bad. And obviously in global health, where there's huge unmet needs and lots of opportunities for technology, this was one of the hackathons that happened in Baylor College. And I'm not sure if you can read these, but this is just some of the examples that they had. It's a broad range of ideas, you know, thinking of like oxygen backpacks and various other things. And these are all now actually funded projects. So top tip is to try and think laterally and think big when you are hacking in a moment. So you're going to get a handout when you go to your little rooms and join your little teams, but essentially it comes up with 3 steps, and it's not super rocket science, but I think if you do it in this way, it will help you sort of structure your thinking. So the unmet need, as we've been told, is sepsis in surgery and LMICs. But you really need to think about why it's important, why is it still an unmet need, and who does it actually affect. So obviously it's an unmet need and we don't want patients to get sepsis, but it affects finance systems, it affects clinicians, it affects policymakers, it affects loads of people as well. So your solution might not necessarily be something for a patient, it could be something to make the surgeon's job easier or so-and-so's job easier. So next, outline any of the challenges. What are the main barriers for addressing this? And many of these will be obvious, but some of them might not be. So it's really good to have our LMIC partners with us to tell us more details about those challenges. Step 3 is to literally, as quickly as you can, almost off the top of your head, ideas about how to come up tackling this problem. It's a huge problem and it's got multiple facets. So it doesn't have to be a one magic silver bullet. It might be something that tackles certain parts of the pathway or coming at it from different angles. Obviously, we all love technology, which is why we're here, and devices and toys and gadgets, but it could also be a product or a service, it could be a system or a process. So there's lots of different types of solution which might be relevant in this case. Step 4, so once you've got all these big ideas, as we've said, only 1% make it through to completion, so you need lots of ideas, but how do you decide which ones are going to be any good or which ones to start investing your time and effort in? So here you can do something called a SWOT analysis, and it tells you about it more on the handout sheet, but essentially it just helps you to structure your thinking around what the strengths, weaknesses, opportunities and threats are. So you'll have to get your phone out and you'll have to Google. The Wi-Fi is not amazing, but hopefully it'll work. And just see what's already out there, see if anyone's done something similar, and that'll help you really sort of kill the rubbish ideas and take the not so rubbish ones forward. Helps frame your discussion, yeah. And then step 5, we're going to ask, you've each got some big pieces of paper and a nice big pen, so we're going to ask you to write your single best idea on there. You need to give your team name a really cool name, like off Dragon's Den, like Phoenix or something cool like that, I don't know. And come up with a cool name for your product as well. Describe the main features and why you think it's good and better, good or where it needs improvement and so on. And you'll have 90 seconds, one or two of each team will have 90 seconds to come on and just pitch it back to us. So we've done the unmet need, and obviously if you forget the unmet need in the next 10 minutes, then we can remind you, but that's what it is, reducing the impact of sepsis. I'm just going to hand over to Hira now, who's going to tell you about the MedTech Foundation, we're the MedTech Foundation, along with other people who help deliver these things.
Thank you. So hi everyone, so I'm Hira, I'm the chair of the MedTech Foundation in Leeds. And so we are a branch of the NIHR Surgical MedTech Cooperative, and we're the branch that focuses on student engagement. And so our main goal is to bring together students to work together with clinicians, engineers, industry reps and academics. And the whole purpose of this is to really get them all working together to hopefully solve unmet clinical needs both locally and globally. So Leeds was the first place where it all started. And since then, we have expanded out. So we now have a hub down in Cambridge, Warwick, Birmingham and Edinburgh. They're all building up, and we're hopefully trying to make this as national as we can. And so as well as diversity as we have nationally, we also have a diverse skill set. So I know a lot of us talk about collaborating with medics and engineers, but the MedTech Foundation isn't just that. So we also have product designers. I'm a medicinal chemist, and even then, all the research projects I've done and will be doing are all based around medical technologies, so we are really a well-rounded team. And so our flagship is our innovation programme. So these take place every single year, all the hubs do it. It's a series of workshops where we get students in multidisciplinary teams, and we guide them through designing a solution to an unmet clinical need. And during these workshops, we also invite guest speakers to help them along the way. They will think of a solution, present it in a Dragon's Den style, so very similar to the hackathon you have today. And the winning team will then have priority to a summer internship. And this summer internship can either be related to the research that they're doing or something unrelated. But if it if it usually is related, and if so, then it means they actually have the chance to implement the research whilst they're still at uni before they've even graduated, which is really amazing. And we've also started these MedX talks last year. So MedX is basically TEDx, but medical related, and each event has a theme, and we invite guest speakers to come and talk about the research which is focused on that theme, and have 10 to 15 minutes. It's very much in layman terms, so it's suitable for everyone, and it really gets the students networking both with each other and also with the guest speakers, and it's just really beneficial for students who don't really network outside the specialty. It's really nice to come to these events and really just talk to people, and engineers can talk to medics about the research ideas, and it has shown in the past that people have actually really collaborated together. And so our internships have been both national, both based at the University of Leeds, and international as well. And so obviously we want to focus on making the MedTech Foundation bigger and better next year. And if you guys really do want to get involved, then please let us know. We do have the MedTech committee members, some of them in the room. If you are a committee member, could you just put your hands up so everyone knows who you are?
Stand up, stand up.
Okay.
Stand up. So these guys will be able to help you out if you get confused during the hack, yeah?
Mm-hmm. Yeah.
Okay.
And so we do have our national meeting in November. It's going to be really, really big. It's always really good. So if you do want to attend and do want to collaborate with us, then please do attend. And that's it from me. Thank you.
Excellent here. Thank you for that quick introduction. So I only got 2 extra followers, so just a quick head up, just follow, and also obviously follow the MIC Foundation. So we're going to be on hand to help throughout the whole process. So if you have any questions, any issues, then let me know. It should be really fun, really intense, and there's refreshments in each of the rooms. But the master organizer actually is Noel, who's going to come on and tell you where to go. You should all know roughly what groups you're in, but I'm sure he can advise more. Thanks, Noel.
Great, well, thanks very much. Good to share the stage with you. I know we are all sort of in a need of some coffee and tea. So what I'll ask you guys to do is, we've divided the groups, the participants into 8 different groups. So you'll be given a number when you got registered. So I hope you all have your numbers from 1 to 8. So
that should be written on your ID badge. And if it's not, then you can pick a room, ideally one which has the fewest people in it.
So we've got some Gasoc members. So we've got Rihanna over there in the front who will help you if you don't know your number. So let's just stick to the number so it's better. So room 1 to 4 would go to room 1, which is you go up to those doors and then go into that corner over there. So that's the biggest room. So we want 4 groups to go over there, and each group will be about 14 to 16. Okay, so each group is going to be of those numbers. And we want other 2 groups, so that will be 5 and 6, to go into the Millennium Room, which is on this floor, where the exhibition was. And then group 7 and 8, we want them to go in the theatre bar upstairs. So that's the plan. And in all of these 3 rooms have got refreshments, so you don't need to all go into one. Just go to where your groups are and get refreshed. Probably give yourself 10 minutes to get refreshed and then start the hackathon. Okay, thank you.
We'll do it later.